Look at your legs right now. If you can see ropey, twisted, blue-purple veins bulging beneath the skin, or if your legs ache and feel heavy by the end of every day, even when you have not exercised, you are watching a structural failure unfold in real time. Varicose veins affect approximately 35% of women and 15% of men in the developed world, according to data from the San Valentino epidemiological study published in the International Angiology Journal. They are frequently dismissed as cosmetic. They are not cosmetic. They are a vascular dysfunction with real downstream consequences, including deep vein thrombosis, venous ulcers, and chronic venous insufficiency that can permanently alter the tissues of your lower leg. And the conventional medical message, either leave them alone or have them removed, misses a critical middle ground where the majority of cases can be stabilized, symptoms reversed, and progression halted without a single procedure. I want to be clear about what I mean by eliminated. For severe, large diameter varicosities with significant valve failure, procedural intervention, endovenous laser ablation, sclerotherapy, or surgical stripping may ultimately be the right clinical choice, and I will tell you exactly when that threshold applies. But for the vast majority of people with varicose veins and chronic venous insufficiency, the correct first approach is a systematic, evidence-based, conservative protocol that addresses the actual mechanisms of vascular wall failure. Most patients have never been offered that protocol. Most have been offered compression stockings and a surgical referral. Those are not the same thing as treatment. Subscribe if you want the kind of clinical depth that actually changes outcomes. I am building a channel for people who want to understand their own physiology, not just manage symptoms. Varicose veins are a perfect example of a condition where understanding the mechanism transforms the entire treatment approach. Let me give you the patient story first. She was 47 years old, a nurse, on her feet for 10-hour shifts, and she had been told by a vascular surgeon that her varicose veins were, quote, a cosmetic issue, and that she could have them stripped if she wanted, but otherwise there was nothing to do. By the time she came to me, she had visible bilateral varicosities from her thighs to her ankles, daily aching and heaviness that began within 2 hours of her shift, ankle swelling that did not fully resolve overnight, and early skin changes near her inner ankles, a brownish discoloration called lipodermatosclerosis that indicates chronic venous hypertension damaging the skin and fat. She was 50 pounds overweight, was not doing any specific lower extremity strengthening, and her diet was heavily processed, high in sodium and refined carbohydrates. She had been told these factors were unrelated to her veins. They were profoundly related. Over 14 months, without any procedures, she achieved complete symptom resolution, visible reduction in the caliber of her varicosities on follow-up duplex ultrasound, and full reversal of the lipodermatosclerosis. How? By systematically addressing the 6 mechanisms I am about to walk you through. Here is the biology. Your venous system is a low-pressure, uphill battle. Every drop of blood that flows to your feet must be returned to your heart against gravity. The system that accomplishes this has 2 primary components: one-way valves inside the veins that prevent blood from falling backward, and the calf muscle pump, the muscular contractions of your lower leg that squeeze the deep veins with every step, propelling blood upward. Varicose veins develop when the valves fail, and valves fail for a specific identifiable set of reasons: elevated venous pressure over time, inflammatory damage to the valve leaflets, weakening of the vein wall itself due to impaired collagen and elastin structure, and hormonal influences, particularly estrogen, that reduce vein wall tone. The medical term for the result is chronic venous insufficiency, abbreviated CVI. The venous blood pools in the superficial veins, which gradually stretch under the pressure until they become the distended, tortuous structures you can see through the skin. The key insight that most people never receive is this: the vein wall and the valve leaflets are living tissue. They are maintained by endothelial cells, the cells lining the inner surface of every blood vessel in your body. and by the extracellular matrix, which is the structural scaffolding made primarily of collagen and elastin. When the endothelium is chronically inflamed, when collagen synthesis is impaired, when oxidative stress is high, the structural integrity of the vein wall degrades. This process is reversible in its early and intermediate stages, not the physical valve incompetence. Once a valve leaflet is permanently stretched or scarred, it does not regenerate. But the vein wall tone, the inflammatory environment, the collagen quality, and the collateral venous drainage can all be meaningfully improved. And this is where the real clinical leverage lies. Step 1. Activate and strengthen your calf muscle pump, aggressively and consistently. This is Tier 1. The calf muscle pump is responsible for approximately 40% of venous return from the lower extremities. Research published in Phlebology has demonstrated that targeted calf muscle training significantly reduces ambulatory venous pressure, the pressure in the veins of the lower leg during walking, which is the primary mechanical driver of varicose vein progression. The specific exercises that matter are calf raises, both straight leg and bent knee to target both the gastrocnemius and the soleus, and walking, not gentle strolling, brisk walking for a minimum of 30 minutes daily, which generates the repetitive calf pump contractions needed to counteract venous pooling. If you are doing seated work for long periods, calf raises from a seated position, 30 to 50 repetitions every hour, measurably reduce venous pooling. This is not a supplement or a procedure. It is a mechanical intervention based on physiology, and it has the strongest evidence base of anything in conservative varicose vein management. Step 2. Use compression therapy correctly and understand what it is actually doing. This is Tier 1. Medical-grade graduated compression stockings, 20 to 30 millimeters of mercury for most patients, 30 to 40 millimeters of mercury for those with significant edema or lipodermatosclerosis, reduce ambulatory venous pressure, decrease the diameter of superficial veins, improve valve function in less severely affected vessels, and reduce inflammation in the vein wall. Research published in the Cochrane Database of Systematic Reviews confirms their efficacy for symptom reduction and slowing disease progression. The key word is graduated. The compression must be highest at the ankle and decrease progressively toward the knee or thigh. Uniform pressure compression does not produce the same venous return effect. They must be put on in the morning before you stand up, while your legs are still drained of gravity-dependent fluid. Wearing them only when symptoms are severe defeats the therapeutic purpose entirely. Step 3. Address the inflammation driving vein wall degradation through diet. This is Tier 1 for the mechanism, Tier 2 for specific dietary protocols. The endothelial cells of the vein wall are directly damaged by oxidative stress and chronic low-grade inflammation. A diet high in refined carbohydrates and ultra-processed foods drives both. Research published in the European Journal of Vascular and Endovascular Surgery has demonstrated elevated inflammatory markers, specifically C-reactive protein and interleukin-6, in patients with chronic venous insufficiency compared to matched controls. Practically, this means reducing refined carbohydrate and sodium intake. Sodium drives fluid retention that directly increases venous pressure, and increasing anti-inflammatory food sources. Flavonoid-rich foods, berries, citrus, dark cherries, purple cabbage, green tea, contain compounds called oligomeric proanthocyanidins and diosmin that have specific evidence for reducing vascular permeability and strengthening vein wall connective tissue. Step 4. Use targeted nutraceuticals with a real evidence base. This is Tier 2, leaning toward Tier 1 for specific compounds. Diosmin and hesperidin, citrus-derived flavonoids, are the most studied natural compounds for chronic venous insufficiency. A preparation combining these, sold under the name Daflon in Europe and available as a generic flavonoid fraction in the United States, has multiple randomized controlled trials supporting its effect on reducing venous inflammation, improving lymphatic drainage, reducing ankle edema, and improving symptoms of CVI. A meta-analysis published in the European Journal of Vascular and Endovascular Surgery confirmed clinically meaningful symptom improvement compared to placebo. The typical therapeutic dose studied is 500 milligrams of the micronized purified flavonoid fraction twice daily. This is not a wellness supplement. In much of Europe, it is a prescription medication for CVI. Horse chestnut seed extract, containing the active compound essin, has similarly strong evidence. A Cochrane review of 17 randomized trials found it superior to placebo for reducing venous edema, leg pain, and itching in CVI, with an effect comparable to compression therapy for symptom control. I want to pause here and ask you to drop your age in the comments. It matters for a specific clinical reason. Varicose veins that begin or worsen in pregnancy have a different hormonal and mechanical context than those that develop in sedentary, middle-aged men. Women over 40 experience declining progesterone, which directly reduces vein wall tone. Progesterone has smooth muscle relaxing effects, and its decline paradoxically benefits arterial tone but can further compromise venous tone. Men over 50 with varicose veins have a statistically higher probability of concurrent deep venous pathology that requires duplex ultrasound evaluation. And for anyone over 60 with skin changes near the ankles, the brownish discoloration I mentioned, or open sores, this is a clinical urgency, not a watchful waiting situation. Age and presentation together determine the appropriate level of investigation. Step 5. Optimize your collagen and connective tissue synthesis. This is Tier 2. The structural integrity of the vein wall depends on the quality of the extracellular matrix, the collagen and elastin scaffolding. Vitamin C is required as a cofactor for the enzymes that synthesize and cross-link collagen. Research from Linus Pauling Institute and multiple clinical studies has established that vitamin C deficiency impairs vascular collagen integrity and that adequate vitamin C intake supports endothelial function and reduces vascular permeability. The target for vascular benefit in the literature ranges from 500 to 1,000 milligrams daily from food and supplement sources combined. Silica, found in horsetail herb extract and certain mineral waters, has traditional use for connective tissue support and some Tier 3 clinical observations supporting its role in vein wall maintenance, but definitive human trial data is limited. Pine bark extract, pycnogenol, has more formal study with research published in Clinical and Applied Thrombosis/Hemostasis showing reduction in leg heaviness, edema, and cramping in CVI patients. Step 6. Manage body weight and intra-abdominal pressure. This is Tier 1. Excess body weight, specifically abdominal obesity, increases intra-abdominal pressure, which impedes venous return from the lower extremities by creating a back pressure against which the venous system must pump. Research published in Dermatologic Surgery has shown that weight loss in obese patients with varicose veins produces measurable reduction in venous reflux on duplex ultrasound, meaning actual improvement in valve function in less severely affected vessels, alongside symptom improvement. Chronic constipation and straining at stool produce the same intra-abdominal pressure surges repeatedly throughout the day, and addressing constipation is a direct varicose vein intervention for this reason. Avoiding prolonged standing without calf pump activation, avoiding prolonged sitting with legs crossed or compressed, these are mechanical pressure management strategies that reduce the cumulative pressure load on already compromised venous valves. Here is the honest summary of when to proceed to intervention. If you have pain at rest, if you have open venous ulcers, if you have had a superficial thrombophlebitis, an inflamed, clotted superficial vein, or if you have symptoms of deep vein thrombosis, including swelling, warmth, and unilateral pain, these are clinical urgencies requiring prompt evaluation. If you have C4 skin changes, the brown discoloration of lipodermatosclerosis, you are at the threshold where conservative therapy alone may be insufficient to prevent ulceration, and a vascular surgery consultation is appropriate. For everyone else, symptomatic varicosities, visible but not complicated disease, the 6-step protocol I have described is the evidence-based first approach that most patients are never properly offered. The veins in your legs can be stabilized. The progression can be halted. The symptoms can be resolved. But it requires understanding that varicose veins are a vascular wall problem, a valve problem, a muscle pump problem, and an inflammatory problem, not simply a cosmetic problem, and treating all of those dimensions simultaneously. Your health is your responsibility, not the pharmacy's. I'll see you in the next video. I want to go deeper on the hormonal dimension of varicose veins because it is one of the most clinically underappreciated aspects of this condition, and it explains why so many women see dramatic worsening during pregnancy, during hormonal contraceptive use, and during perimenopause, and why men who develop varicose veins after 50 are a distinct clinical population. Estrogen and progesterone both act on vein wall smooth muscle. Estrogen, in high concentrations, relaxes vascular smooth muscle, which is why it has vasodilatory effects. But at sustained high levels, it also increases the expression of matrix metalloproteinases, enzymes that degrade the collagen and elastin scaffold of the vein wall. During pregnancy, circulating blood volume increases by 40 to 50%. Estrogen and progesterone levels are dramatically elevated, and the growing uterus compresses the inferior vena cava and iliac veins, the large vessels returning blood from the lower extremities. All three of these factors together produce a perfect storm for varicose vein formation and rapid progression. Research published in the journal Obstetrics and Gynecology has shown that up to 40% of women who develop varicose veins during pregnancy retain them permanently after delivery, particularly if compression therapy was not used during the pregnancy. Combined oral contraceptives containing synthetic estrogen similarly increase venous distensibility, the ease with which veins stretch under pressure, and are associated with both the development of varicose veins and an elevated risk of deep venous thrombosis. This is well-established pharmacology, Tier 1 evidence. For women who already have significant venous insufficiency, this is a conversation worth having with the prescribing physician when considering hormonal contraception options. Perimenopause presents a different but related picture. As progesterone levels fall more rapidly than estrogen in the early menopausal transition, the net effect on vein wall tone is a loss of support. Progesterone has specific smooth muscle effects that, while sometimes producing venous dilation in excess, also contribute to structural vein wall integrity when in appropriate balance with estrogen. The interplay is complex, but clinically, many women notice an acceleration of varicose vein symptoms in their mid to late 40s that directly correlates with the hormonal transition. This does not mean that hormone replacement therapy is indicated for vein health. The evidence for that specific application is not there, but it means that the pelvic floor, the abdominal musculature, and the calf pump, all of which support venous return and are affected by the physiological changes of menopause, require specific attention during this period. For men, varicose veins that develop after 45 or 50 are more often associated with occupational factors, prolonged standing in tradesmen, long-haul drivers with prolonged sitting, and with metabolic factors including insulin resistance and elevated BMI. The same venous inflammation pathways apply, but men are statistically less likely to seek care early and more likely to present with advanced CVI features. Research from the Edinburgh Vein Study, a landmark epidemiological study of over 1,500 adults in Scotland, documented that men with varicose veins had a substantially higher rate of concurrent deep venous pathology than women, making duplex ultrasound evaluation more clinically urgent in men with symptomatic disease. There is also a significant genetic component to varicose veins that I want to address honestly, because patients often feel that their genetics make conservative intervention futile. It is true that family history is one of the strongest risk factors. If both parents have varicose veins, your lifetime risk approaches 90%. The genetic factors appear to involve genes related to vein wall connective tissue quality, venous valve development, and inflammatory signaling. Research published in Nature Communications identified multiple genetic loci associated with varicose vein risk through a genome-wide association study of 400,000 participants. But here is the critical clinical truth. Having a genetic predisposition to vein wall fragility means that the environmental and lifestyle inputs I have described, inflammation, weight, intra-abdominal pressure, cath pump strength, nutritional adequacy for collagen synthesis matter more for you, not less. Genetics loads the gun. Your daily choices determine whether and when it fires. Let me also address the sleep position and elevation question, because it is something patients ask about constantly. Elevating the legs above the level of the heart during rest genuinely improves venous return and reduces the pressure in the distal venous system. Research published in Phlebology shows that leg elevation reduces ambulatory venous pressure by a measurable margin and acutely reduces ankle swelling. The practical recommendation for patients with symptomatic CVI is 15 to 30 minutes of leg elevation at a 45-degree angle, feet above the level of the heart, in the afternoon, and ideally sleeping with the foot of the bed elevated by 6 inches rather than using pillows under the calves, which can compress the popliteal vein behind the knee. This is a zero-cost, zero-risk intervention with direct mechanistic rationale. It does not reverse valve damage, but it reduces the cumulative daily pressure load that drives progression. One final mechanism I want to bring into this picture is the lymphatic system, because it is inseparable from venous health in the lower extremities, and it almost never gets mentioned in discussions of varicose veins. The lymphatic system runs in parallel with the venous system and serves as a secondary drainage pathway for interstitial fluid, the fluid that leaks out of capillaries into the surrounding tissue. When venous pressure is elevated and capillary filtration increases, the lymphatic system takes on a compensatory load. Over time, if the lymphatic system is overwhelmed, interstitial fluid accumulates. This is the edema, the swelling, the heaviness. The lymphatic vessels of the lower extremity are driven by the same calf muscle pump that drives venous return, which is one of the reasons why walking is so therapeutically powerful. It activates both systems simultaneously. Specific manual lymphatic drainage techniques, a form of gentle massage that follows the anatomical pathways of the lymphatic system, have clinical evidence for reducing lower limb edema in CVY, documented in a systematic review published in the Journal of Vascular Surgery, Venous and Lymphatic Disorders. This is a therapeutic option worth discussing with a physiotherapist trained in lymphatic drainage. The 6 steps I outlined are the core protocol. But understanding the hormonal context, the genetic backdrop, the lymphatic dimension, and the specific triggers that accelerate progression allows you to customize that protocol to your actual clinical picture. Varicose veins are not destiny. They are a signal that specific biological systems need specific support, and that support is available, evidence-based, and largely within your control. I also want to address nutrition with more specificity than I did earlier, because this is where people get either confused by conflicting advice or overwhelmed by supplement lists that are not prioritized. Let me give you the evidence hierarchy clearly. First priority, hydration. Dehydration concentrates the blood, increases its viscosity, and makes venous return more difficult. It also impairs the lymphatic system, which relies on adequate fluid volume to function. Research from the Journal of Physiology has shown that even mild dehydration, a 2% reduction in body water, measurably impairs cardiovascular efficiency. For venous health specifically, the practical target is a minimum of 2 liters of water per day, increasing with exercise or heat exposure. Coffee and tea, despite their mild diuretic effect, contribute net positive fluid intake for most regular consumers and do not need to be avoided. Second priority, reducing sodium and increasing potassium. Excess sodium drives fluid retention and directly increases the extracellular fluid volume that the venous and lymphatic systems must manage. Processed and packaged foods are the overwhelming source, not the salt shaker. The average processed food diet delivers 3,000 to 5,000 milligrams of sodium per day, against a recommended maximum of 2,300. Potassium counteracts sodium's fluid-retaining effect and supports vascular smooth muscle tone. The richest dietary potassium sources are sweet potatoes, avocados, spinach, beans, and bananas. Research from the American Journal of Clinical Nutrition has shown that dietary potassium intake is independently associated with lower rates of hypertension and vascular disease. Third priority, the flavonoid-rich foods I mentioned earlier deserve a specific practical list. Daily consumption of berries, blueberries, blackberries, tart cherries, dark leafy greens, citrus pith, the white part, which is richer in hesperidin than the juice, green tea, and dark chocolate above 85% cacao provides the dietary flavonoid foundation that supports vascular wall integrity. These are not exotic foods. They are available, affordable, and have cumulative mechanistic benefit for the endothelium. Fourth priority, and I want to be clear, this is tier 2 evidence, is grapeseed extract. Standardized grapeseed extract containing oligomeric proanthocyanidins has been studied specifically in chronic venous insufficiency in multiple small randomized trials, with results showing reduction in leg heaviness and edema. The evidence is promising, but not yet at the level of the diosmin-hesperidin combination I described earlier. If budget is a consideration, the citrus flavonoid combination is the higher priority investment. The consistent theme across all of these nutritional strategies is the same: reducing vascular inflammation, supporting collagen integrity, reducing fluid retention, and providing the building blocks that the endothelial cells of the vein wall need to maintain their barrier and repair function. Food is not a dramatic intervention in the way that a procedure is, but compounded daily over months and years, it is arguably the most powerful modifier of vein wall health available to you. Everything I have described today, the calf pump work, the compression, the anti-inflammatory nutrition, the targeted nutraceuticals, the weight management, the collagen support, these are not workarounds or substitutes for real treatment. They are the real treatment for the vast majority of people with varicose veins. The procedure is what comes if and when this foundation is genuinely insufficient. Start with the foundation. Build it consistently. Give it 6 months of honest effort with proper assessment. The outcome will tell you clearly whether you need the next step.